Okay. Good afternoon, everyone. Prof. Nnodu really needs no introduction. She's well known. She's Professor of Hematology and Blood Transfusion, and she's also the director of CESAR-PA, so the director of Center for Sickle Cell Disease Research and Training. Prof. Nnodu is also a founding member for Sickle Charter and vice chair for the Sickle Cell Support Network in Nigeria, the SCSSN. She's a site PI for Sparkle and about, I think, almost 30 sites nationwide that she's responsible for in Nigeria. So without further ado, Prof. Nnodu, the floor is yours. Most welcome.
Yeah. Good afternoon, everyone, and Happy New Year, even though the last day in January. I'm delighted to make this presentation on newborn screening for sickle cell disease in Africa. And I'm going to use the following outline. I'll give a background, the rationale, discuss protocols, training, tracking, care of screen-detected babies, delivery systems, and we're going to consider how feasible and acceptable newborn screening is, what the challenges are, what the possible alternatives are, and how we can go beyond the norm of pilot projects to national newborn screening programs and what we must do now. And I'll leave us with a little take-home message. So globally, we have an estimated 465,000 babies are born annually with significant disorders of hemoglobin. Of these, 401,000 are with sickle cell disease, and 70 to 75% of these are in sub-Saharan Africa, with Nigeria and the Democratic Republic of Congo very highest burden of this. So more than half of the babies born with sickle cell disease in sub-Saharan Africa will die before their 5th birthday, while 90% will die before attaining adulthood if poorly managed in childhood. So the basic interventions for the control of sickle cell diseases, including raising public awareness about sickle cell disease, newborn screening, screening for sickle cell disease at primary healthcare centers, establishing a registry of patients with sickle cell disease for prospective follow-up, prophylaxis for infection, administration of pneumococcal vaccines, oral penicillin, use of insecticide, treated bed nets and anti-malaria, health maintenance at PHC, and then of course comprehensive care through integration into secondary and tertiary healthcare centers. Genetic counseling is very important, as is adequate nutrition that takes care of the calories that these individuals are burning up, education of parents and caregivers about sickle cell disease and the patients, and then what to do with the condition in crisis before coming to the hospital, emphasizing optimal hydration. And hydration means that they drink enough water for their pee to be white. And so these are, of all of those interventions, newborn screening has been demonstrated over many years through the cooperative trials in North America. And evidence from these studies justify newborn screening. It was seen that babies who had more babies with sickle cell disease survive when they are identified at birth than those who are identified later in childhood. And then it was also shown that babies who receive prophylactic penicillin soon after birth were less likely to have fetal bacterial infection, and also that invasive pneumococcal disease in children given pneumococcal vaccines the prevalence of that was significantly reduced. And so these evidence from these studies justify newborn screening. And that is why babies are identified soon after birth so that they are given penicillin prophylaxis, pneumococcal vaccines. And then, of course, when hydroxyurea therapy became available to this population of patients, they were seeing that it was quite effective, also in reducing stroke, and then chronic transfusion therapy. So all of these, have helped to extend the life of people with sickle cell disease by decreasing the morbidities associated with them. And this is really what has happened in high-income countries that we are seeking to implement in sub-Saharan Africa. And so it's very important that we understand that newborn screening is a 6-part system that includes education, screening, diagnosis, short-term follow-up, management, and evaluation. But it's not only sickle cell disease. You have actually established newborn screening program that deals with a whole host of congenital disorders, congenital hyperthyroidism, toxoplasmosis, inborn errors of metabolism, and then, of course, we are concerned about sickle cell disease and thalassemia, as well as other hemoglobin variants. What are the approaches to screening? To newborn neonatal screening. So there's the available technology is that of a heel stick. More rarely, cord blood can be used. And then the testing platforms include isoelectric focusing, HPLC, high performance liquid chromatography, capillary electrophoresis, mass spectrometry, and recently, point of care tests. You will notice that hemoglobin electrophoresis is not included there because of the high level of fetal hemoglobin that tends to interfere or crowd off the A and the S so that they cannot be identified easily. And there is the benefits of this is that the heel stick isoelectric focusing is widely implemented. There is a lot of experience in some countries with that, and the benefit is abundantly demonstrated, but it's labor intensive and requires extensive expertise, as some of the CONSA programs are getting to know that it does require expertise. HPLC and capillary electrophoresis are used in newborn programs in the UK and France, but the high cost of equipment and reagents makes it a little bit difficult to sustain in sub-Saharan African countries. Mass spectrometry has a very high cost of equipment, but extremely high throughput, and many of those inborn errors can also be detected, at the same time. And what is happening now is the opportunity for point-of-care tests, and point-of-care testing has been successfully implemented in some African countries, such that in Nigeria, there's evidence of benefit from Haiti, Ivory Coast, Ghana, and Martinique, and these countries have done newborn screening with point-of-care tests. So this is just a diagram that is showing us isoelectric, the conventional diagnostic methods, which is the usual, cellulose-assisted electrophoresis that is present in most secondary healthcare centers and maybe some primary healthcare centers. Then isoelectric focusing on the MyGel, Pekinelma MyGel platform, then high performance liquid chromatography. And I've tried to put some of the pictures, of the kind of separation that you get with each of these. And you can see from this slide that the subject of newborn screening has been received attention from many clinicians and researchers across sub-Saharan Africa. And they've identified, tried to see, is it feasible? Is it something that we can do? How do we actually do that? And a number of review papers and white paper has been written, just to try and describe, what the challenges are and how this can be implemented. But, so it's important that when we want to establish newborn screening programs, there has to be careful planning. That planning should involve the public health personnel, the government in that country, because this is a public health program. There ought to be leadership, there has to be education, medical, education of healthcare workers, education of, the technical skills that need to be used even in the screening. And then, of course, logistics support, the supply chain management, policy. It has to be backed by a policy, what to do, when to screen, how to give out the results, and then the administration of the program has to be taken care of. So, and then there has to be a plan in place for evaluation, because the reason that you want to test is you actually want to track the babies that are identified and then monitor the impact of the interventions on them. And for the program to be sustainable, it has to be embedded in the public health system of the country. So sustainability requires an integration of all system components for a fully functioning system. And it relies on local Ministry of Health endorsement and support with budgetary allocation. And so people have wondered, should this be a free program, or are we going to try to recover costs? Can we embed these in maternity services? And you can see as the presentation goes on that many countries have tried different scenarios. So the delivery system for newborn screening is hospital-based in Ghana, in Benin, in Nigeria, Angola, Senegal, and Tanzania. And some of these ones also use immunization clinics as practice in Ghana and Nigeria. And then some systems like Uganda, countries like Uganda have embedded it in the HIV early infant diagnosis with IEF, and Malawi also has taken this route. And this slide is showing us the papers on newborn that have come out of Africa, sub-Saharan Africa, the year of publication, the country or city, the duration of the particular study, and then the number of babies that are screened, and the frequency or prevalence of sickle cell disease from the studies, and the test methods. So you can see that many of these countries are actually using isoelectric focusing, and yet within these countries, it's still a relatively new technique that people are still not quite used to. And then also, this is talking about targeted, versus systematic. So targeted means that you're not screening every infant that is born in that country, but rather that you're screening the infant of mothers born, of mothers that have sickle cell trait. So you only screen those babies because you cannot have a mother with a baby from a mother who does not have a sickle cell trait. So, and then the sample, most of them are heel prick on filter paper. Only in Burkina Faso did they report the use of cord blood, and some, so it's dry blood spot. You can see that the program in Ghana has been the one that has, it's now in about 16 years, in its 26th year, having started in 1996. So Ghana is an example of an African country with growing and sustained newborn screening program, as exemplified by the Black Star. That is the Black Star. This is actually credit to Professor Kwaku Ohene-Frempong, who was funded by the NIH when he was director of the cooperative Sickle Cell Center in Children's Hospital, Philadelphia. So he was funded to start the newborn screening program in Kumasi at the hospital, teaching hospital, and the university in collaboration with the Ministry of Health and the Ghana Health Service. And the screening laboratory was at the Neguchi Memorial Institute for Medical Research in Accra, Ghana. And the program is really a model program, of the protocol, the data collection, the collation, handling of samples, performed by the nurses, and then integrated with very good recall rates and follow-up rates. And the overall supervision of the program is by a national newborn screening nurse coordinator. And recently, a wonderful innovation has been put into the program with the use of mobile data collection, such that data is collected into a mobile app, and then the workers in the screening laboratory have, and then reports are taken. So everything now is mobile and with very little paper interface. However, we will say that in 26 years, the government is yet to fully fund the program, and it has not expanded to a national program despite detailed plans for this to happen. And the other program that is worthy of note is the newborn screening in Uganda using the early infant diagnosis HIV screening platform. And you can see that this is really an example of an integration or piggyback of newborn screening using an existing public health program. And so they were able to define the burden of sickle cell disease and the geographical, and then do targeted screening in those areas of high burden. So the careful planning is essential, when we want to set up newborn screening programs. Details about where the samples will be collected by the healthcare workers, when the samples will be collected, if it's at birth or birthing institutions, at postnatal clinic, usually between 2 and 6 weeks, at first immunization, where the screening laboratory will be cited, and the test to be used for screening and confirmation, what happens to the results, the personnel responsible for parental follow-up and scheduling clinic visits, when and where the confirmatory testing will be conducted, the clinical network for the follow-up and care of babies detected through the program, and who and how they are going to get their drugs and immunizations, because after all, the important thing is that is the reason that people are able to, that's why the screening is being done, so that they can be followed up and appropriate interventions they are given. Then the data management workflow and the personnel charged with that, and the quality control of the program. So all these must be worked out by any country that wants to initiate newborn screening program, so that the impact of the program can be determined or evaluated and determined. So the protocol is important. The protocol is what people will use. Everyone in the program will adhere to the protocol, deals with sample collection, movement and transport of samples, not only the sample collection, but the data that we accompany the samples, that are collected and information that will help the program managers to track the babies afterwards, and counseling of parents whose babies have abnormal results. Protocol describes all of this, as well as laboratory testing, the follow-up, what should be captured in the database, and the management. And so there are available resources for follow-up. One is the WHO PEN Plus program of intervention for non-communicable diseases in primary health care. This has actually worked out in detail what happens to the babies and how the primary health care centers are integrated or strengthened, the referral system strengthened in order for babies identified at lower levels of care to be able to get adequate help and to access comprehensive care. And SPACO also has a multi-level standardized guideline, which has a home level, the primary health care, secondary and tertiary healthcare levels. And of course, the American Society of Hematology has a protocol on newborn screening that also includes the family education. And so people have wondered, seeing how detailed this program is in high-income countries, is there any possibility that the rest, the high-budget countries can actually, or are they going to accept it? And then the resounding answer is yes, that it is acceptable, it is cost-effective, it is acceptable. In our study in Nigeria, where we looked at the 6 geopolitical zones, 86.1% of parents and students and patients with sickle cell disease said that they will accept newborn screening. And so the International Committee of Experts are willing to support the establishment of newborn screening in sub-Saharan African countries. And you can see that they were talking about this for a while before they became implemented. But there are obstacles and challenges. And the most important of this is the failure to realize the contribution of sickle cell disease to infectious diseases, malnutrition, and poor health statistics in high-budget countries. And Nigeria is actually the first and only country so far to include the sickle cell disease in the demographic health survey in 2018. And we found out from that survey that 1.3% of children, according to that survey, have sickle cell anemia. 68 of them have anemia. 68% of the children have anemia. And 10% of these children with anemia have sickle cell disease. Nobody would have known the import of the contribution of sickle cell disease to anemia in children, as the focus had always been on malaria and iron deficiency. So the children with sickle cell disease, it was also found, were 4 times more likely to die than AA children. And not only that, their older siblings in the same house suffered 99 excess deaths per 1,000 live births compared with children whose younger siblings only had the AA genotype. Nobody would have seen this if it was not that, for this simple reason that Nigeria included sickle cell disease in the demographic survey. So we have a policy that exists, but on newborn screening in the country, but it's not yet receiving the priority and attention that it deserves. And consequently, there is no budgetary allocation to the sickle cell disease program. And this is not unique to Nigeria. Many sub-Saharan African countries, with the exception of Benin Republic, do not have budgetary allocation for newborn screening in their country's budget. So the consortium for newborn screening in Africa was born as an initiative of the American Society of Hematology. It's an initiative to enhance newborn screening in 7 sub-Saharan Africa countries, Liberia, Ghana, Nigeria, Uganda, Kenya, Tanzania, and Zambia. And the consortium is a collaboration between the American Society of Hematology and hematologists across Africa, intended to demonstrate the effectiveness of newborn screening and early therapeutic interventions for babies with sickle cell disease in sub-Saharan Africa. The consortium has also been able to negotiate lower equipment and reagent costs for newborn screening on the Perkin-Elmer isoelectric focusing platform. And so across these countries, there's one national coordinator per country. And so this table is telling us the country and who the national coordinators are, and then the hospitals where the newborn screening program or the institutions. So the aim of the consortium or the activities is to screen between 10,000 to 16,000 babies per year in each country, to enroll the SCD positive babies in a clinical protocol and follow them up to 5 years of age, to capture screening and clinical data in a consortium registry for further research, and to work with national and international partners for the sustainability of the program. And as of January 13th, 2022, 23,405 babies so far have been screened. Of these, 21.26% have sickle cell trait, while 1.14% have sickle cell disease. Of the babies identified, 55 are in follow-up care. So, some of the things it's good to know, overall, all 7 country sites have begun screening. The focus is now on implementation and ensuring laboratory, data management, and clinical quality. Continued need to sensitize communities on sickle cell disease diagnosis and care of newborns. The impact of COVID has caused like a delay in supply chain logistics for materials, and also resulting in lower numbers of babies screened. But we anticipate that the numbers will rise as the pandemic has started waning. For sustainability, several country governments have a plan to scale up newborn screening, but this has to be backed up by budgetary allocation and funding. So there's a need for sustained advocacy, armed with the kind of data that is coming out of that demographic survey from Nigeria, to make a case for investment, and so that local, regional, and national governments will actually begin to fund early intervention programs, while pursuing partnerships with industry like Perkin-Elmer and Novartis to fund some aspect, or to support some aspect of the screening and intervention. For Nigeria, we have been carrying out awareness campaigns since the launch of the program to promote screening and care of babies with sickle cell disease. The total number that has been screened is 5,752, and out of these, 29.06% have sickle cell trait and 1.02% have sickle cell disease. So one of the challenges that we have when I'm zeroing in on the CONSAR program in the Federal Capital Territory, as you can see the white distribution in that map, that's a map of the Federal Capital Territory. The teaching hospital where I work is located, where the pediatric sickle cell program is located in this trough, just beneath. But you can see the red dots are the 19 centers, primary healthcare centers across the Federal Capital Territory, where the babies are being born and being detected through the immunization programs. whereas many mothers are willing to go to those immunization programs to receive the penicillin and to receive intervention, they have shown a little bit of unwillingness to come to the teaching hospital because of the distance. And so we have had to make arrangements to fetch them and bring them as enrollment in the clinic within the first 3 months is mandated in the program. So there are some challenges with going to the pediatric sickle cell clinic. And actually, this is something that we have to work out whether there's another way that a follow-up can be done. And if you look at, this is just a brief description of the program in Nigeria. The country has actually made an investment in for newborn screening about 10 years ago when they bought the BioRad NBS new HPLC machines and placed them in each of the 6 geopolitical zones. And then, but due to the high cost of reagents and the skill that is required, some of the machines were not being used and even some reagents expired. But there are some initiatives by some states like Anambra State and Delta State, Kaduna State, Southwest Zone states. Now, Southwest Zone of the Sickle Cell Support Society NBS program that is being planned. So these programs are underway, to varying degrees, and we are beginning to get some data, come out of them, and they are all based on the isoelectric focusing, and one program or the other have some Nigerians in diaspora, helping to push those programs. Then I will not fail to mention the SCORE, the sickle cell cohort research study led by Baba Yunusa that screened over 10,000 babies in North Central Nigeria. They were under 5s, and they were able to establish the prevalence in that region. And then, of course, in the Federal Capital Territory is the program that, a screening program that started from a Doris Duke Foundation funding in 2007, where we piloted newborn screening in our local government using point of care. And this was the basis upon which the concept was now started, because that platform had been established. But the concept program is using isoelectric focusing. So this started in 2017 and is ongoing. And so now we have 10,000. We have screened over 10,000 babies in the Gwagwalada as well as other centers in the FCT. But one of the things that we notice as a main challenge is reluctance of mothers to attend the pediatric sickle cell clinic at the teaching hospital, which is some distance from many of the primary healthcare centers. So the newborn screening programs in Nigeria, so the blue boxes are where the federal government newborn screening centers are established. So we see overall that judging from the way the best run programs in Africa have remained pilot programs over decades without achieving national coverage, Nigeria adopted this multi-site approach, to their newborn screening program. And then that's the ones that are based at the MDG centers. The the assay that is being used is HPLC, which is costly. And so over a period of time, we looked at innovative point of care tests. When we found out that these were good and can be used in the newborn, we evaluated the feasibility of using that in our area council. And then when we found that they were cheap and reliable and can be done with basic training, even in remote villages, this point of care test, we implemented it, and we published that paper in Lancet Hematology 2 years ago. So the screening methods that can be used in low resource settings are point of care tests and confirmatory testing at the government screening, newborn screening centers. So the country has actually, the policy on non-communicable diseases advocates point of care tests for universal screening and confirmation by IEF or HPLC. And the point of care tests, there's two frontline ones that have differing costs, and point of care tests have been included in the essential diagnostic list of WHO. So these are some of the point of care tests. And so this map is a map of Nigeria prevalence among 6 to 59-month-old children, estimated from the Nigerian 2018 Demographics Health Survey. And so these are the centers with the Sickle Pan-African Research Consortium network are located in the black dots, these cities with the black dots as well as the red dots. The black dots are established sites, and the red dots are the new sites in that Sickle Pan-African Research Network in Nigeria. So the newborn screening for sickle cell disease based on an easy-to-use point-of-care screening can be implemented in multiple primary health care settings alongside immunization programs in areas of high prevalence without substantial investment in the equipment. So having proven this strategy, having tried it, so this is the strategy that we want to use to scale up newborn screening. But being a high-budget country, we cannot wait for 26 years for a small pilot somewhere to now scale up into a national program. We have to use innovation to drive progress in this area in our country. So that is based on the studies that we have done, and studies from other parts of the world. Higher budget countries may note and choose to incorporate in its own EDL list these point of care tests for universal screening. So, but it's not enough to identify the babies. They have to be followed up. The babies need to be followed up. And this is very crucial, because if the babies are, after being identified, are not followed up, it's almost the same as if nothing has been done. So post-test counseling is very important, and with the aim of enrolling that baby into care to receive infection prophylaxis. So of course, the confirmatory testing has to be done. Then genetic counseling to families, not only those with the disease, but also those that have the trait, so that they know the long-term implication of that. Then education and training, both for parents and healthcare workers, are important. And linkage to pediatric parent support and other support groups are very important. Enrollment of babies into centers that can provide comprehensive care are quite, important. So how do we deal with the challenges of parents not willing to accept results when the baby looks normal? It's just to have a constant probe of education of the public and education. And then we also have to guard against babies who are lost to follow up, because sometimes babies, parents will take the mothers when they are pregnant to the villages or to where they have more support. They will have the babies, and then they will now go back to their original place. So there's also difficulty in tracking babies with no house addresses. Ghana has used this, and then the use of GIS has been effectively utilized in other disease conditions, and we are considering some of these in order to track. And when we talk about interventions, we kind of looked at what African countries were doing in terms of medication. Are they providing insurance? What is happening? So pneumococcal vaccines, 15 countries are providing pneumococcal vaccines as a result of the Gavi. But it's only Senegal that has health insurance. So governments are paying for the vaccines, as that are part of MPI. Some governments are even paying for anti-malaria prophylaxis, supposedly from the malaria program, and then no government is paying for oral penicillin. And this is really important, because these are some of the things that give rise to overwhelming sepsis, for which they are dying within the first 5 years. So, but in most countries, the patients are the ones paying, for these. They are the ones paying for their drugs. So what are we supposed to do now? Well, we generate publicity to create user demand. Programs that have started that may have a problem with getting. Okay, programs that have started that have with having the numbers. So public education on newborn screening is important to understand, how critical it is to intervene early when the babies have been identified. Then advocacy for budgetary allocation for NBS in countries and health insurance cover for families. And then support for production of ISO, that's information and education communication materials. And then pharma also needs to support early intervention aspects of the program. So advocacy is quite critical. And then especially advocacy that is tied to real figures of burden, will go a long way. So in Nigeria, what we have multi-sectoral collaboration, working together with the Ministry of Health, the MDG sickle cell centers, and then also the Sickle Cell Support Society of Nigeria that has a widespread geographic.
I think Prof. Nnodu may have lost connectivity. We're coming to the top of the hour. We did start 10 minutes late. So ideally, we should be able to continue another 10 minutes if people do not mind, while we wait for Prof. Nnodu to rejoin. Please feel free to post your questions in the chat box, as some people have already started doing. So thank you. Yeah. So let's just give a few more minutes. The video recording of this presentation will be made available shortly after via YouTube. So if you've arrived late, you should be able to capture and gather everything that Prof. Nnodu has talked about. So yeah, welcome back, Prof. Nnodu. You can continue. We have about 8 minutes left to make a complete hour. We started 10 minutes after the hour. So yeah, so we have about 8 minutes. I think people would like to ask questions. I personally know I would like to. So please continue, Prof.
Mario.
Yes, ma'am.
Okay, I'm back.
Sure, just give me a sec. I'll just give me a sec. There we go. Yeah.
Okay, thank you.
So we have, yeah, sure, we have about 8 minutes left, yeah?
Okay, I'll soon round up. So this production of the IES information, education, and communication materials, electronic, to be shared via social media, legislation, for increase in funding, or even, initial funding, integration of newborn screening into early infant diagnosis and maternal and childcare services that are really well funded, and generating awareness of the presence of NBS service and creating demand for it by patients, and then creating awareness on the need for follow-up so parents don't disappear with babies in denial after screening. So these are all multi-sectoral collaboration is essential to be able to achieve the goals of newborn screening. And the follow-up of screen-detected babies, so these are they need to have penicillin, they need to have the vaccines, they need to start hydroxyurea from 9 months, traditional support, crisis management, stroke prevention, through Doppler ultrasound scanning, transfusion, whereas and when necessary, and education. These are all important. And so the approach in Nigeria is to use is a multi-site newborn screening. We can't afford to start from one site, and we want to use implementation science, to drive this. The strategy is to integrate points of care. Yes.
Could you please share your screen again? We stopped sharing presentation.
Okay. Sorry. Okay. Okay.
Thank you.
Okay. Yeah. So the approach that we want to adopt in Nigeria is to use this partnered sites, which are clinical centers that are in all the geopolitical zones. There are 25 of them, and make them the hub of the newborn screening. So they will work together with the MDG centers, sickle cell centers in their zones. And then we are using the point of care testing. So that's the strategy that we want to use the point of care test screening, integrate that into existing immunization programs, allow encryption of test results into patient health smart cards, and to monitor the patients along the care cascade. So that is what we want to use, using implementation science framework of Eric and Ryan. So we want to determine the effectiveness of this tailored intervention strategies to integrate sickle cell disease screening into immunization program. We want to demonstrate adoption, implementation, and maintenance of integrated sickle cell newborn screening program. We also want to demonstrate reach, acceptability, and usability of the card, My Health Card, among mothers of infants presenting at immunization clinics. And we want to develop implementation research, mHealth and mHealth related research capacity among research teams at the SparkNet collaborating centers. So our approach is to use hybrid type 3 step wedge cluster randomized trial across 24 immunization clinics. And the framework is the integrated EPIC and RE-AIM framework. So we want to explore, we want to prepare, implement, and then see the sustainability and then translate the research into practice. So essentially, that is what we want to do in Nigeria. The policy for the country's policy for non-communicable diseases is in support of the use of point-of-care tests for universal screening. And then we want to use that in order to scale up newborn screening across multiple sites, because we cannot afford to wait for one site to progress slowly over time. All the babies in Nigeria need to be found on time. So sickle cell disease is a genetic blood disorder in high prevalence in sub-Saharan African countries. And we want to, newborn screening, there's evidence that it saves lives, newborn screening and interventions saves lives of individuals with sickle cell disease. But we really feel that sub-Saharan African governments need to have budgetary allocation for newborn screening, and multi-sectoral partnerships are necessary to achieve universal newborn screening in high-burden countries. So the program for Nigeria, we use a combination of standard methods of IEF in CONSA sites and HPLC in MDG sickle cell centers with point of care testing for more remote areas in order to implement newborn screening for the country. So thank you very much. I'm ready to take your questions. Thank you.
Thank you very much, Prof. Nnodu. For a non-clinical person like myself, it was extremely interesting. I know your time is precious. We have come to the end of the hour. So I know that we officially are ending this session, but you are willing to stick around to answer questions, correct?
What happened is that my audio was right to the bottom.
Okay, can you hear us now?
Yes, I can hear you.
There, welcome back. Most
Thank you.
Back. Sure.
Yes.
So before, Julie had a question, but before we go there, there were some questions in the text box. Yes. One question, Vicky was saying that, I don't know, forgot what the context to that is. Vicky, if you could provide context, what if people in the private care systems? All of these are lost. Vicky, would you be able to provide context to that question quickly? Because I forgot where exactly the question was asked.
Yes, so I think my question was around most of the newborn screening programs that are kind of being pushed forward are all in the public healthcare and even the education of the parents. And I'm just wondering whether we are also missing out a large chunk of the population, especially those who attend private healthcare facilities.
Yes, certainly we are, Vicky. And that's why in Abuja, what we are trying to do in the next phase is to have a massive public enlightenment campaign using radio, using social media, so that would create awareness about the program. And of course, if private hospitals, I've had colleagues, tell me, oh, we are interested. And I say, sure, we will come and teach your people how to collect the GBS, because after all, the state primary healthcare development board has asked us to screen across the FCT or the primary healthcare center. It's just that there are few of us. And so we are willing to, and they should be encouraged to screen the babies. We can give them the forms and then teach them how to screen the babies, and they will be able to partake in the program. So they shouldn't be lost. They shouldn't be lost, because some private hospitals may use the immunization programs near them. But if they are able to collect the samples themselves, we should be able to include them.
Thanks, Prof. If you want to ask a question verbally, please raise your hand, and I'll ask you to unmute, and you can ask your question. I hope I pronounce your name correctly. Olaitan Awe is asking, are there biomarkers or list of genes that screening programs use when screening for neonatal diseases in general, especially SED, inborn errors of metabolism, and where is the screening protocol published?
Oh, okay. So there is, you may have seen in one of my first slides, I put a list of conditions that typically, some of the established screening programs would have. So there's a Society for Newborn Screening, and they have, many panels, up to 40, even more. So the panels, for the biomarkers that they're looking for, they are expanding. But the only thing is that we haven't even started any kind of screening. But we feel that once we start with newborn screening for sickle cell disease, we can now add, like G6PD, and then we add hypothyroidism. And in Nigeria, the pediatricians are talking about adding other things to that panel. But in more developed countries, high-income countries, if I may say that, they have already established with many panels that there are many disease entities that they are looking at. So,
thanks,
yeah, I can see Risi Wesong is talking about implementation. My dear, you can't have implementation without funding. There has to be budgetary allocation for newborn screening by African governments. And we have to make that advocacy. We have to demonstrate the case for investment, and we have to say, look, if you're not paying attention to this, you're not going to be able to meet your MDG, your health-related SDG goals. We have to make that case.
I'm not sure whether it's a follow-up question, Obi, but you mentioned that after 29 years or so, Ghana, the government of Ghana has not made a concerted effort. That's not what you said. After 29 years, there's no government-driven funding. It's not mandatory, but so yeah. Why is that? Is that part of the? Why is that, if I may ask?
Okay, so it's 26 years actually. The government is funding the program where it started in Greater Kumasi region, but it's not a detailed plan for expansion of the newborn screening program has been made for several years, up to 10 years, in fact, to roll out this program to the rest of the country. But the government has not funded that rollout. But Pfizer and Novartis, have been helping, to fund, some aspects of the program. And I think the government of Brazil was also offering some technical cooperation. But the government of Ghana, and indeed not just Ghana, many African countries, it's only Benin Republic under with Sharif Rahimi's influence that has succeeded in getting that government to put newborn screening in their budgets. And so it's well funded. But
Thanks.
even then, that is, they are using targeted screening, and the program is not all over the country, but is in the capital.
Thanks for the response, Obi. Julie, please go ahead and ask your question. Julie, are you still online? Okay, so let me just unmute.
Yeah, Julie's hand is still raised. Julie, you can ask your question.
Let me just unmute her. There we go. Julie, please unmute yourself. There we go.
Thank you. So just check, because the host does not allow you to unmute. So it's possible that some people have questions. I just wanted to commend Professor Obi and the work that is being done in Nigeria. Nigeria is really the lead in terms of providing us with experience, expertise, in terms of implementation and making this a multi-center national program. So I really wanted to commend Professor Obi's leadership of the work that is being done in Nigeria. I was just wondering whether you might want to say a little bit about how the work in Nigeria informs or will inform the work that is going to be done as part of Sickle in Africa with regards to implementation research and consortium level newborn screening, and how you envision the collaboration or how this will complement existing activities in countries such as Ghana, Nigeria, Benin, Tanzania, but also how they will also complement existing initiatives such as CONSA, as well as other newborn screening initiatives that are being done, just to show that what we're intending to do is, and this is again something that you've demonstrated or you've talked about in your presentation, in that we want to complement what is already there rather than set up a new thing. So I just want to, it's more of a comment for you to expand a little bit further. Thank you, Professor Obi.
Yeah, you're welcome. So, when you're looking at, thank you very much for that, Julie. So when you look at, like when I was looking at just how long it has taken Ghana, to achieve, the newborn screening program since 1996. And so it's conventional, it's standard, the well-organized, but moving very slowly. And I can imagine, the CONSA countries, it's one center per country, except for Nigeria, that is 2 centers. Assuming we take the next 5 years with CONSA, just doing the newborn screening in Abuja, the rest of the country, they are getting impatient. They want to have a go, and so what we did, I think, can be a model for other countries. What did we do? The government has 6 newborn screening centers, MDG sickle cell centers. And the government started newborn screening in those centers. So when we found out that we could not afford we wanted to do newborn screening, we couldn't afford it, but we had tested we had evaluated the point of care tests, and we saw that they were as good as HPLC. So we started in our own local government, in the primary healthcare centers in our local government, using point of care. We did that for 2 years. And the number of samples we were able to screen were more than the government centers that had stayed there for 6 years, 8 years. You understand? So we were working in partnership with the government, because we were confirming our results with the nearest MDG sickle cell center. You understand? So in a similar way, CONSA has come in different countries. It's going to take, CONSA is only screening 10,000 babies per year in each country. 10,000 is small. It's very, very small compared to the need out there. So in a similar way, these CONSA sites can be sites where using standardized methods of screening, they can act as reference laboratories. But the more rural areas where the physicians are that have interest, like we have clinical networks, there are 25 clinical networks across the country. Each of those 25 networks are going to start using POC, backed up by the national policy, to start screening newborns there, and then linking the babies to those referral centers. You understand? Working in tandem with the government-established programs. So that is the way. So this model that we have tried here in our local government, we are going to implement it across the country, and it can be a model for other countries. So how are we going to do this? Like in other countries that started from one teaching hospital, but have now expanded the SPACO sites to other centers. So depending on the expertise and depending on the public transport system, they can decide to use POCT in remote areas and then take, use the send samples for confirmation in the more established concert sites. So they can work hand in hand. But we really don't have 25 years to wait for a program to grow until we get, because the babies are being born. So once the protocol, the same protocol, concert protocol can be used, the only thing is that the laboratory aspect will be POC, point of care test. But the protocol on what to do, how to look after the babies, how, the care will be the same concert protocol. So CONSA has provided us with the tool to be able to implement newborn screening according to, but we have to obviously be innovative if the resources are not there in order to reach the rest of the babies through the use of point of care tests. And of course, the education, the skills development, we are teaching the primary healthcare workers through our SPACO skills development program. We are teaching the laboratory personnel, through the Pekinelma Consa SPACO relationship collaboration. So we train the healthcare workers, we train the nurses, we train the physicians, and then we will be able to implement it. We don't have 25 years more to wait, for this to happen. And the good thing is that the SPACO sites are also the CONSA sites. Most of the SPACO sites are also in CONSA, so it can be done.
Thanks very much, Obi. I think let's give 2 more minutes and then we'd be past the hour. If there are any other questions, just one single question, please raise your hands. And Julie, to your point about muting everybody, in the public webinars such as this, I think it's best that we restrict permissions for attendees as much as possible, as long as it's not preventing anybody from having proper discourse and open discourse. Okay, so we've got 1 minute to past the hour. Prof. Nnodu, I've got lots of questions, but it was just that interesting. So thank you very, very much. It was interesting. It was well presented. And it's obvious that you've done a lot of work. And yeah, you are, as Prof. Mokani said, are to be commended for all of your energy invested. So thank you very, very much.
Yeah, thank you very much. Thanks for listening. Thank you, Julie, for your leadership. Thank you.
Thanks everyone, and goodbye.
Yeah, thank you.
Sure. The presentation will be uploaded to YouTube by the end of today. I'll probably send a mail to everybody who's registered once it's done.
Okay.
Thanks, Obi.
You're welcome.
Goodbye, everybody.
Okay, bye-bye. Thank you.